Welcome to one and all present here. Today I am going to discuss about etiology of malocclusion, especially in orthodontics. So in orthodontics there have a lot of problems, skeletal malocclusions, dental malocclusions and soft tissue problems are existing. So I am going to elaborate the various categories of malocclusion and causes of malocclusion. Various authors they have given the classification of malocclusion. Okay, let's discuss one by one. So before going to the topic, I am going to introduce one proverb. Eyes cannot see what the mind does not know. It means some kind of orthodontic problems cannot identified, but some problems may be seen visibly. So some that problems have a some kind of causes. Okay, specific causes, predetermined causes. So comprehensive orthodontic management, it involves identification of possible etiological factors and an attempt to eliminate the same. Although it may not be possible, it is nevertheless of value in preventive and interceptive procedures. Okay. Then malocclusion. Malocclusion is an interaction between genetic and environmental factors. So statistical analysis of malocclusion, they are given in the pie chart. So for the reference, you can see this chart. So malocclusion groups. Malocclusion may involve four tissue systems: teeth, bones, muscles, and nerves. So another way to classify malocclusion is to divide them into three groups: dental dysplasia, skeletodental dysplasia, and skeletal dysplasia. So coming to the classification of etiological factors of malocclusion, first one is McCoy's classification, second one is Moyer's classification, third one is Salzman's classification, fourth one is White and Garner's classification, fifth one is Profit's classification, sixth one is Graeber's classification. So coming to the McCoy's classification. In McCoy, they given classification of malocclusion, direct causes and indirect causes. So coming to the indirect causes, hereditary, congenital, prenatal abnormalities, acute and chronic infections, metabolic disturbances, endocrine imbalance, unknown causes. So next, determining direct causes: missing tooth, supernumerary teeth, transposed teeth or malposed teeth, abnormal labial frenum and intrauterine pressure, sleeping habits and posture, pressure habits, abnormal muscular habits, malfunctioning muscles, premature shedding of deciduous teeth, delayed eruption of permanent teeth, prolonged retention of deciduous teeth, loss of permanent teeth, improper and dental restoration, that means quality restoration. Then Moyer's classification, it can further divided into hereditary type, developmental defects of unknown origin, then trauma and physical agents, habits, diseases and malnutrition. Salzman's classification, it's a diagrammatic representation of the etiological factors in malocclusion, that means genetic, environmental, congenital and functional. So these are the causative factors of malocclusion. Then White and Gardner's classification, dental base abnormalities, anteroposterior malrelationship, vertical malrelationship, and lateral malrelationship, and disproportion of size between teeth and basal bones. Then congenital abnormalities. Then pre-eruption abnormalities are abnormalities in position, missing teeth, and supernumerary teeth, and teeth abnormal in form, prolonged retention of deciduous teeth, large labial frenum, and traumatic injury. Profit's classification, there are specific causes of etiology. malocclusion, disturbances in embryological developmental teratogens, that means drugs. Then skeletal growth disturbances, intrauterine molding, birth trauma to mandible, childhood fractures of the jaw, muscle dysfunction, acromegaly and hemimandibular hypertrophy, disturbances of dental development and congenital missing teeth, malformed and supernumerary teeth, interference and with eruption, ectopic eruption, early loss of primary teeth and traumatic displacement of teeth, and genetic influences and environmental influences. So coming to the Grebus classification, most commonly used classifications are Grebus classification. It divided into general factors and local factors. General factors are hereditary, congenital defects, environmental defects, predisposing metabolic climate and diseases, dietary problems, abnormal pressure habits and functional aberrations. Local factors are anomalies of number, supernumerary teeth, missing teeth, congenital absence or loss of teeth, that means anomalies of tooth size and shape and labial phenome, premature loss of deciduous teeth, prolonged retention, delayed eruption of teeth, abnormal eruption, ankylosis, dental caries, and forte restriction. So, coming to the general factors in Graves classification, heredity type. A child may have a facial features that markedly resemble those of mother or father or both. It is also to be noted that a single gene is not responsible for particular malocclusion. It may be due to the combined action of different types of gene. It may lead to significant changes: tooth size, width and length, height of palate, crowding and spacing of teeth, overjet, position and conformation of perioral musculature, size and shape. Soft tissue peculiarities, facial asymmetries, macrognathia, micrognathia, macrodontia, oligodontia, and anodontia, and tooth-shaped variations, pectoralis, cusp of carabelli, mammalians in the incisors, cleft lip and cleft palate, diastemas, deep bite, rotation of teeth, mandibular retrusion, mandibular prognathism. That means class 3. In congenital defects, cleft palate, torticollis, cleidocranial dysostosis, cerebral palsy, syphilis, then cleft lip and cleft palate. Congenital defects like cleft lip and palate separately or in combination are among the most frequent congenital deformities in the human. It is not often possible for the dentist to compensate for residual post-surgical abnormalities. In the unilateral cleft, the teeth are one side are usually in lingual crossbite with the opposing lower teeth. Many times the premaxilla is displaced anteriorly or because of the tightly repaired lip. The whole premaxillary structure is forced lingually. The maxillary incisors is in type or badly malposed axial inclination. The area of cleft teeth are often jumbled. Maxillary lateral incisor may be missing or faint. Torticollis means shortening of the sternocleidomastoid muscle causing profound changes in the bony morphology of the cranium and the face. It characterized by dry neck, bizarre facial asymmetries are uncorrectable if not treated early. Then cleidocranial dysostosis, maxillary retrusion and possible mandibular protrusion, retained deciduous teeth, retarded eruption of permanent teeth, short and thin permanent tooth roots, supernumerary teeth. These are the features of cleidocranial dysostosis. Cerebral palsy, paralysis of lack of muscular coordination due to intracranial lesions, complete lack of motor control resulting in abnormal muscular function in mastication, deglutition, and respiration. Abnormal pressure habits, it leads to malocclusion. Then congenital syphilis is also type of tooth morphology abnormalities. That means archings and incisors, marbelli molars, enamel deficiency like enamel echinacea, extensive dental decay, maxilla may be smaller in size related to the mandible and the cross bites. Then environmental factors, prenatal and postnatal. Prenatal, it may be lead to drugs and abnormal fetal posture, rubella, maternal infection, postnatal, birth injury, trauma and scar tissue, Milwaukee braces. The prenatal, some of the drugs induced teratogens, that means chemical and other agents capable of producing immunological defect, it given as a called teratogens. These are the teratogens causing problems. Then intrauterine molding. Pressure against the developing face prenatally can lead to distortion of rapidly growing areas. That means examples, an arm is pressed across the face in utero, resulting in severe maxillary deficiency. Other factors that may affect are trauma, maternal diet, maternal metabolism, germinal. Then postnatal birth trauma, childhood fractures, then extensive cord tissues from a bun may produce malocclusion. Then birth trauma it may lead to TMJ problems, ankylosis, internal hemorrhage, and subsequent underdevelopment of the mandible. Then predisposing metabolic climate and diseases. So endocrine diseases are most commonly coming to the predisposing metabolic climate, hypoparathyroidism, and hyperparathyroidism. Hypothyroidism, some of the dental related problems, that means decreased rate of calcium deposition in bones and teeth, that means 8 grams per deciliter of normal calcium level. It comes to below 8 grams per deciliter, it may lead to hypothyroidism. Abnormal root resorption patterns, delayed eruptions, gingival disturbances, retained deciduous teeth, irregular teeth arrangements. Then coming to hyperthyroidism, premature eruption, disturbed root resorption, hyperparathyroidism, delayed eruption, altered tooth morphology, hypoplastic teeth. Hyperparathyroidism, demineralization of bone, distortion of trabecular pattern, teeth may become mobile due to loss of corticosteroids and resorption of alveolar bones. Acromegaly, which is caused by the anterior pituitary tumor that secretes excess amount of growth hormone. Excessive growth of mandible may occur, creating skeletal class 3 malocclusion in adulthood. Also, multiple root resorption may be found. Nutritional deficiency, disturbances such as rickets, scurvy, and beriberi can produce severe malocclusions. Main problem is upsetting of the dental developmental timetables. The resultant premature loss, prolonged retention, poor tissue health, and abnormal eruptive pulse leads to malocclusion. Abnormal pressure habits, thumb sucking, finger sucking, pacifiers, tongue thrust and tongue thrusting, lip biting and nail biting. Dentofacial changes associated with prolonged non-nutritive sucking habits are increased proclination of upper incisors, increased maxillary arch length, increased clinical crown length of maxillary incisor, increased atypical root resorption in primary central incisors, increased retroclination of mandibular incisors, increased overjet, decreased overbite, increased unilateral and bilateral cluster occlusion, increased lip incompetence, tongue thrust, speech defects, especially lisping. Then lip bitings, lip habits, it may lead to proclination of upper anteriors and retroclination of lower anteriors, hypertrophic and reductant lower lip, cracking of lips are present. Nail biting, it may lead to minor changes in the surface of the incisors. It may lead to wear of incisor edges and minor crowding may be present. Tongue thrusting habit, with condition in which the tongue makes contact with any teeth anterior to the molar during swallowing. It also must be remembered at the time that there is a controversy regarding tongue thrust is an etiological factor of anterior open bite. According to the Grabus and Moyes, tongue thrust definitely leads to an anterior open bite. Profit contraindicates this fully, and according to him, it is an already existing anterior open bite that leads to tongue thrusting habit. Proclination of anterior open bite, bimaxillary protrusion, posterior open bite in case of lateral tongue thrust, and posterior crossbite. Then mouth breathing habit, it may result in altered jaw and tongue posture, which could alter the orofacial equilibrium, thereby leading to malocclusion. Long and narrow face, expressionless face appearance, short and flaccid upper lip, contracted upper and large with possibility of posterior crossbite, increased overjet as a result of flaring of the incisors, dryness of the mouth predisposed to caries, and anterior bruxism, grinding of teeth for non-functional purposes, occlusal wear, fracture of teeth and restorations, mobility of teeth, tenderness and TMJ pain. Tongue sizes as well as function of important concession. Aglossia, it may lead to narrow arch and crowding. Macroglossia can lead to widening of dental arch, spacing and bone bite. Functional aberrations, abnormal swallowing habits, improper deglutition, speech defects, respiratory abnormalities, mouth breathing, tonsils and adenites, psychotics and bruxism, posture, trauma and accidents. Local factors, anomalies in number of teeth, supernumerary teeth, missing teeth, congenital absence are due to loss of accident, caries. Supernumerary teeth, that means mesodents presence between the two central incisors, it may lead to spacing. Lateral peglateral incisors and congenital absence of premolars and paramolars. Missing teeth. Congenital absence due to accident or caries. Order of frequency. Maxillary and mandibular third molar is the first order. Second is maxillary lateral. Third one is mandibular second premolars. Fourth one is mandibular incisors. And fifth one is maxillary second premolars. Abnormalities of tooth size. Frequently it has been noted that one maxillary lateral incisor will be of normal size while the other is small. Anomalies of size are relatively frequent in the mandibular premolar area. Anomalies of tooth shape mainly is a peg lateral leads to excessive spacing. Anomalies of shape occur as a result of developmental defects like amelogenesis imperfecta, hypophagia, germination, densindent, odontomas, fusion, and congenital syphilitic aberration, Hutchinson incisor, and multiple molars. Labial plenum, it may lead to spacing in between the two central incisors. In this type of cases, frenectomy is indicated. Premature loss of deciduous tooth should be considered as a malocclusion maker. Deciduous teeth not only serve as organs of mastication but also as a space saver of permanently. Loss of the deciduous second molar will lead to mesolity of the first permanent molar and blocking of erupting second premolar. In these cases, appropriate space maintenance should be given. It may lead to mesialization of first molars. Prolonged retention and abnormal resorption of deciduous teeth. If the roots of the deciduous teeth are not resorbed properly, uniformly, or scheduled, the permanent successor may be either withheld from eruption or that may be reflected into the malocclusion. Delayed eruption of permanent teeth, endocrine disorders like hypothyroidism, presence of supernumerary teeth or deciduous tooth, mucosal or bony barrier may be present. Abnormal eruption path, severe crowding, supernumerary teeth, retained deciduous teeth, bony barrier, dentigerous cyst. Another form of abnormal eruption is referred to ectopic eruption. Most common form is a permanent tooth erupting through the alveolar process causing resorption on a contagious deciduous teeth or permanent teeth rather than a predecessor. Example maxillary first molar causing resorption of maxillary deciduous second molar. Ankylosis, the partial ankylosis occur relatively frequently during 6 to 12 years of period. Ankylosed disease teeth should be identified and treated by removal of building of surgical subluxation along with space maintenance. Permanent teeth can also be found to be ankylosed can be due to accidents, trauma, congenital disease like cleidocranial dysostosis. Number of dental caries it will causes malocclusion. So prevention is better than cure. So yearly diagnosis of caries can be treated yearly. So improper faulty restorations may be lead to changes. Silver mercury alloy restoration have a tendency to flow under pressure. Large proximal restoration change gradually under the occlusal forces and arch length is increased. This may result in creation of broken contacts, rotations, crossbite conditions, and functional prematurities. Lack of anatomic details in restoration of cuspal areas of a tooth may permit elongation of opposing tooth. So supraeruption. Loose contacts can also lead to food packing. Teeth tend to move apart and also lead to bone loss. So conclusion, malocclusion results from genetic, environmental, dental, skeletal and systemic factors. Understanding its etiology, helping in early diagnosis and treatment planning. By addressing underlying causes, orthodontists can prevent worsening conditions, improve function and aesthetics, and enhance the long-term oral health, ensuring optimal outcomes for patients requiring orthodontic care. So thank you for listening. Thank you.